Good afternoon. I'm Dr. Charles Geyer. I'm not Dr. Angela DeMichelle. She's been hung up in another session, so we're going to have a change in order. I was scheduled to go third with my presentation, but I will take the lead. So we ask your indulgence on this. Before beginning, I need to declare that I have no conflicts pertinent to this presentation to disclose. Neoadjuvant systemic therapy has a number of established clinical utilities, which include conversion of patients with inoperable tumors to operable candidates and conversion of mastectomy candidates to candidates for breast-conserving surgery. Cosmetic outcomes can also be enhanced by reducing the size of a lumpectomy for larger tumors. Patients at low risk for local, regional, and systemic recurrences can be identified based on pathologic response using criteria such as PCR, residual cancer burden, or clinical pathologic criteria such as the CPS-EG system proposed by Andy Anderson. Finally, neoadjuvant chemotherapy can provide time for genetic counseling and testing, as well as careful consideration of surgical management options before proceeding with surgery. The strong association of PCR with event-free survival and overall survival has been well established, and the strength of that association is demonstrated on this slide from a recent international meta-analysis on neoadjuvant therapy led by the FDA and reported at San Antonio. However, retrospective data from MD Anderson has suggested that PCR in biopsy-proven nodal metastatic disease may have an even stronger association. As shown, patients with proven nodal metastatic disease had a 10-year recurrence-free survival of 87% compared to only 38% in those with residual axillary disease. Also of interest, on the right is that the presence of documented axillary CR seemed to obviate the importance of PCR in the breast in terms of outcome. Patients who have a PCR in the breast and axilla could potentially derive additional benefit from their neoadjuvant therapy if the extent of axillary surgery and/or local regional radiation therapy could be reduced or even eliminated. These have been active areas of investigation, which I would like to now briefly review. Neoadjuvant therapy, of course, was initially developed in an attempt to convert inoperable, incurable locally advanced breast cancer to operable and potentially curable breast cancer by administering chemotherapy prior to mastectomy, axillary dissection, and radiation therapy. While the majority of patients presenting with locally advanced breast cancer will be found to have residual disease at surgery, a minority will have a PCR. One could consider eliminating radiation therapy in this subset of patients with highly responsive tumors. MD Anderson has taken a retrospective look at patients in their institution who presented with stage 3 breast cancer and received neoadjuvant chemotherapy. Decisions on use of radiation therapy were individualized, and not surprisingly, the group that received radiation therapy had a substantially higher risk for recurrence based on prognostic factors than those who did not. This was not a randomized controlled study. This was basically just looking back at experience. In spite of the higher risk, though, for recurrence of the patients receiving radiation therapy, as you can see on the left, there were much fewer local regional recurrences, and more significantly on the right, this was associated with marked reduction in the incidence of distant metastatic disease. Therefore, patients who present with locally advanced breast cancer clearly require radiation therapy regardless of the magnitude of response to their neoadjuvant treatment. Fortunately, the number of patients presenting with locally advanced breast cancer has declined, and a large majority of patients present with operable breast cancer. Management goals for newly diagnosed operable breast cancer include molecular characterization of tumor, complete imaging of breast and axilla, pathologic evaluation of imaged axillary nodes with consideration for core biopsy or fine needle aspirate of suspicious or abnormal nodes, and sentinel node evaluation for normal nodes on imaging. And while we want to avoid local regional recurrence and avoid systemic recurrence, we also want to avoid overtreatment. Let's initially focus on patients with abnormal or suspicious axillary nodes on imaging. One option for management is initial surgery followed by standard adjuvant chemotherapy and radiation therapy. Unfortunately, with this approach, there is no potential opportunity for avoiding axillary dissection or radiation therapy. In contrast, neoadjuvant therapy provides opportunity for sentinel node evaluation in responding patients. Of course, this is not the setting in which sentinel node techniques were originally developed and evaluated, so investigators have made efforts to understand the performance of the technique in the post-neoadjuvant setting relative to the standard setting. In 2009, Kelly and colleagues reported a meta-analysis of nearly 1,800 patients from 24 single and multi-institution studies that evaluated the performance of sentinel node biopsy following neoadjuvant chemotherapy. Their study demonstrated an estimated identification rate of 90% and a false negative rate of 8.4%, which certainly are comparable to characteristics of sentinel node biopsy in the standard setting. There was clearly a wide range reported in these studies, but the average values were certainly in line with the pre-neoadjuvant results. Recently, though, results from two large multi-institution prospective registry studies conducted in Germany and North America were reported at San Antonio that I think provide additional important information. The Sentina trial, conducted by German investigators, employed axillary ultrasound to characterize nodal status in candidates for neoadjuvant therapy and used those findings to guide therapy. Patients with normal axillary nodes underwent initial sentinel node biopsy followed by neoadjuvant therapy. I will review those data later in my presentation. For now, I want to focus on the patients who had abnormal nodes on imaging. 41% of the patients in the study were classified as having CN1 disease and received neoadjuvant therapy followed by repeat axillary imaging. 83% of these patients had normalization of the axillary nodes and underwent sentinel node biopsy followed by axillary dissection. The 17% of patients with persisting imaging abnormalities proceeded to axillary dissection. The post-neoadjuvant sentinel node identification rate was 80%, somewhat lower than the identification rate reported in the standard setting and in the meta-analysis. And the false negative rate was somewhat higher at 14%. 52% of patients with abnormal nodes on imaging at presentation had no evidence of axillary metastases at surgery, demonstrating substantial downstaging, though we know that a portion of the patients presenting with abnormal nodes on imaging did not have tumor present initially. ACOSOG Z1071 evaluated the post-neoadjuvant sentinel node biopsy procedure in patients presenting with biopsy-proven axillary nodal involvement, so this study provides a better estimate of the axillary downstaging. 40% of patients with biopsy-proven nodal mets had clearance of their axillary disease with neoadjuvant systemic therapy. The sentinel node identification rate was 93%, substantially higher than reported in Sentina. However, the false negative rate was 12.6%, essentially the same as reported in Sentina. Thus, the prospective multi-center registry studies suggest that the false negative rate in the post-neoadjuvant setting may be numerically higher than in the standard setting. However, the absolute difference is small and, in my opinion, is insufficient to warrant abandoning the procedure if the overall benefits justify its usage. So let's assume the answer to the question of the suitability of a sentinel node procedure in the post-neoadjuvant setting is yes. What are the options for the 48 to 60% of patients with a positive sentinel node? Well, the standard approach would be to proceed to axillary dissection followed by radiation therapy. But what about the possibility of eliminating the axillary dissection and addressing potential remaining nodal disease with radiation therapy alone? This question is being addressed by a randomized trial coordinated by Alliance in which patients who have positive sentinel nodes after neoadjuvant therapy, who had a positive node documented, will be randomized to basically receive standard radiation therapy without axillary dissection or undergo axillary dissection along with radiation therapy. So this is a question that is being addressed with the clinical trial. Well, what about the substantial number of patients with documented downstaging from neoadjuvant therapy, the 40 to 52% of patients that we saw in these two studies? Certainly, they would not undergo axillary dissection, since avoidance of axillary dissection is the main reason performing sentinel node biopsy. The more challenging question is in regards to the need for regional node radiation given the documented axillary PCR. When considering eliminating radiation therapy in this setting, it is important to review the benefits of the modality in node-positive patients undergoing initial surgery and receiving adjuvant chemotherapy. An important manuscript from the Oxford Overview on this issue was published in 2005. These cumulative incidence curves shown on the slide demonstrate the effectiveness of regional radiation therapy in lowering the risk for local regional recurrence in both the node-negative group in the upper left-hand panel, as well as the node-positive groups in the lower left-hand panel. However, the magnitude of the absolute risk without radiation therapy in node-negative patients is small, so the absolute risk reduction is even smaller and did not result in improved long-term survival. However, in node-positive patients, the absolute risk without radiation therapy is substantial, as is the relative risk reduction. This resulted in a long-term survival advantage shown in the lower right-hand corner. A 4-to-1 rule has evolved based on the recommendations of the authors of this manuscript that basically states that the avoidance of 4 local regional recurrences with radiation therapy will lead to avoidance of 1 death from breast cancer. And it seems that the consensus of the radiation oncology community has been that an absolute local regional risk of at least 10% is needed to justify the expense and morbidity of radiation therapy. So I think it's reasonable to employ that standard for considering omitting radiation therapy in the post-neoadjuvant setting. Another important contribution to the literature in this area was provided by the NSABP late last year with publication of a retrospective look at local regional recurrences in B18 and B27. The trial designs are summarized on this slide. 356 local regional recurrences were identified as first events among nearly 3,100 patients prospectively randomized in the 2 studies. Importantly, use of chest wall and regional radiation therapy were specifically prohibited in both trials, so potential biases from use of radiation therapy are not an issue in this data set. Nodal status was determined by axillary dissection in both these trials, though some investigators also elected to perform sentinel node biopsy prior to axillary dissection. Overall, the local regional recurrence rate was 12.5% at 10 years for patients undergoing mastectomy and 10.5% for those undergoing breast-conserving therapy. Predictors for 10-year local regional recurrence were evaluated and included clinical and pathologic characteristics before and after neoadjuvant therapy. B18 and B27 encouraged use of FNA at a time for diagnosis, at a time ER could not readily be assessed on FNA in specimens, so potentially important predictors such as ER and HER2 are not available. With that caveat, though, you can see that age, tumor size, and clinical nodal status at entry were important pretreatment characteristics that predicted for local regional recurrence. However, post-therapy breast PCR status was also an independent predictor of a similar magnitude to those pre-therapy predictors, and axillary PCR status was the strongest of all the predictive factors. When the predictors were then evaluated again by choice of surgery, tumor size dropped out for lumpectomy and age dropped out for mastectomy. So let's look at the results according to the independent predictors, focusing on the patients who presented with clinically node-positive disease. For women aged 50 and above treated with breast-conserving therapy, local regional recurrences were less than 10% if the axillary nodes were negative, regardless of the PCR status in the breast. patient with positive nodes clearly had local regional recurrences above 10%. However, in younger patients undergoing breast-conserving therapy, only those with PCR in the breast and nodes had a local regional recurrence rate under 10%, demonstrating the contribution of age as an independent risk factor in patients treated with breast-conserving surgery. With mastectomy, it appears that the only patients with local regional recurrence less than 10% were those with PCR in the breast and nodes. So it appears that while a PCR in involved axillary nodes provides important information, the PCR status in the breast may provide important additional information, particularly in terms of determining if the local regional risk meets the threshold for radiation therapy. This NSABP data set is important for hypothesis generation and providing some practical clinical guidance, but a prospective trial to better define risk of local regional recurrence and obtain information on subtypes is needed. And Energy recently initiated this bookend trial to the Alliance study, in which patients who are diagnosed with biopsy-proven axillary nodal disease and receive adjuvant therapy, but are found to have PCR in the nodes at axillary evaluation, are then randomized to receive nodal radiation or not. They go, obviously women with breast-conserving therapy still receive treatment to the breast, but this is determining if the radiation therapy to the regional nodes can be eliminated. Let's now turn our attention to the more common setting of newly diagnosed breast cancer with normal axillary nodes on imaging. In this situation, timing of sentinel node biopsy is a key issue and has been a subject of some controversy. In 2008, the NCI held a statement of the science conference which summarized the advantages of each of the two approaches. I've highlighted what I consider to be the main justifications for each of the two approaches. Let's return to the Sentina trial now and focus on the cohort with normal nodes on imaging at presentation. This portion of the study basically evaluated a compromise position between the pre- and the post-neoadjuvant sentinel node biopsy groups by performing the procedure twice in patients who had a positive sentinel node identified prior to neoadjuvant therapy. 35% of the clinically node-negative patients on ultrasound who were candidates for neoadjuvant therapy, in the opinion of the investigators, were found to have an initial positive sentinel node. Investigators reported an extremely high sentinel node identification rate of 99% prior to neoadjuvant therapy, but only a 61% identification rate with a second attempted procedure following neoadjuvant chemotherapy. Of even greater concern was the false negative rate of 52% in that situation. Thus, it would appear from this data that the performance of the proposed compromise is simply not acceptable for routine clinical use. So let's go back and look at the management flow of patients who undergo an initial sentinel node biopsy. The 65% of patients found to have negative nodes don't require any axillary evaluation after neoadjuvant therapy, so for them the procedure was useful. However, the 35% with an initial positive sentinel node will need to undergo axillary dissection and will have lost the opportunity for downstaging assessment. Patients with PCR in the breast and nodes at axillary dissection will be candidates for avoiding radiation therapy, but the patients with residual disease will still require radiation. In contrast, patients receiving initial neoadjuvant systemic therapy will be candidates for post-therapy sentinel node biopsy, except in the very rare occurrence of progressive disease in the breast and axilla during neoadjuvant therapy. Those found with positive sentinel nodes will require radiation therapy, but will be candidates for the Alliance study and may avoid axillary dissection. Those with negative sentinel nodes will be candidates for the Energy study and so may avoid radiation therapy. So I think there are distinct advantages to performing sentinel node biopsy after neoadjuvant therapy. In my remaining time, I would like to just spend a few moments discussing another advantage, I think, of neoadjuvant therapy relative to adjuvant therapy, and that is the opportunity for post-neoadjuvant residual disease trials. Patients with high-grade tumors such as triple-negative breast cancer treated with neoadjuvant therapy have a substantial risk for recurrent disease if residual invasive cancer is found in their surgical specimen, essentially 50% in this data set from the meta-analysis. Patients with HER2-positive residual disease following neoadjuvant chemotherapy have a similar high risk for recurrence, particularly if ER-negative. Presently, there are no therapies with known efficacy to offer these patients other than initiation of endocrine therapy for ER-positive patients and completion of the standard one-year duration of HER2-targeted therapy. Because of the high recurrence rate in these patients, they are appropriate candidates for clinical trials evaluating promising new agents. The most recent HER2-targeted therapy for metastatic disease approved for patients with progression after prior treatment with a taxane and trastuzumab is T-DM1. Approval was given based on the results of the Amelia trial, the schema of which is shown here. These well-publicized results showed improvement in progression-free survival by 3 months with a hazard of 0.65, and a second interim analysis showed improvement in overall survival by 6 months with a hazard of 0.68. The activity and safety profile provided a strong rationale for evaluating the agent in the high-risk post-neoadjuvant setting, even though it had only been recently approved for second-line metastatic breast cancer. The NSABP and the GBG, along with other global investigators, recently activated the CATHERINE trial, shown here, to evaluate T-DM1 as an alternative to continuation of trastuzumab in this setting. Studies of a similar design are under consideration for other cancers such as triple-negative breast cancers, highly proliferative ER-positive breast cancers, so investigators and their patients receiving neoadjuvant therapy will have opportunity to participate in this new type of clinical trial. So in summary, ultrasound of axillary nodes with biopsy of suspicious nodes should be a component of standard evaluation of newly diagnosed invasive breast cancer. Neoadjuvant therapy is preferred for patients with suspicious axillary nodes, particularly if metastatic disease is confirmed by biopsy. Neoadjuvant therapy with post-therapy sentinel node is preferred for chemotherapy candidates with T2 or T3 primary tumors and normal axillary lymph nodes on imaging. Energy and the Alliance are addressing key local regional management issues related to neoadjuvant therapy with current trials. And I do think the post-neoadjuvant residual disease setting offers a new option for high-risk patients with residual disease. Thank you for your attention.